Welcome to the Deep Dive. Today we're opening up the playbook on an issue that causes a huge amount of private confusion and stress.
A huge amount.
We're talking about female sexual health, and specifically the difficulty some women have in reaching orgasm.
Right.
We're going to be looking at a clinical consultation, basically giving you a confidential shortcut to understanding the mechanics, the psychology, and the actual treatment plan.
And our mission here is to really pull this topic out of the shadows. We're going to extract the cold, hard facts, bust some really stubborn myths.
There are so many.
Oh, yeah. And we're going to provide a clear, actionable framework so you can understand this whole interaction of physical, psychological, and even relational factors.
And before we dive into the details of the case, we have to start with the data. Because if you are struggling with this, the most important thing to hear first is that this is not rare.
It is absolutely not rare. If you're listening and this resonates, the immediate message is you are not broken.
That's so important.
The numbers are, they're staggering, really, when you see them. We're talking about roughly 10% of women who never reach orgasm.
10%.
That's the clinical diagnosis, primary anorgasmia. But then you broaden that out, and something like 40% of women struggle with it regularly.
40. Wow.
So yeah, you're part of a massive group of people navigating a very complex process.
That completely reframes the whole discussion. It shifts it from, what's wrong with me to, okay, what do I need to learn about my body and my mind?
Exactly.
So let's start where the consultation did. Step one, always, is a medical checkup.
That's the bedrock. You have to do it. Before you even get into the psychology, you have to rule out any physical roadblocks.
Like what specifically?
Well, the doctor is looking for things that affect nerve transmission or vascular health. So chronic illnesses like diabetes, thyroid issues, hormonal imbalances, they can all dampen the whole sexual response cycle.
And medication is a big one, right? The consultation really highlighted certain antidepressants.
That's a huge one. SSRIs, for example, are fantastic for mental health, but they are notorious for interfering with sexual function. They can sort of flatten the emotional experience you need for release.
Okay, so you have to rule all that out first.
You do. You also look at things like prior pelvic surgeries or any history of trauma that could affect muscle function. But in this case, there was a critical pivot point.
Right, the way the patient described her own experience.
Yes, exactly. She said she could feel desire, she could feel arousal, she could feel all that physical tension building up, that plateau phase. But then
It just stops.
it just stops. The wave builds, and then it just fizzles out before it can crash.
So what does that one detail tell a clinician?
That's the clue. It means the desire and arousal systems are working just fine. The body is responding. The block is in that final involuntary reflex, the release.
So the issue isn't a lack of capability. It's a communication breakdown between the brain and the body.
Precisely. And in her case, since she'd never experienced one, the diagnosis was primary generalized anorgasmia.
Which sounds very technical.
It sounds technical, but it's just a label. And the most important part of that diagnosis was the reassurance that came with it. Your anatomy is capable. The challenge is just unlocking that connection.
Okay, which is a perfect lead into our next section, because so much of this starts with, well, just bad information about female anatomy.
Yeah.
Let's talk about the clitoris.
Yes. We have to spend some time here. A lack of good information is, it's a major blocker.
Right.
The source material really dives into the complexity of the clitoris. We're talking about a structure with over 8,000 nerve fibers.
Which is, what, more than double the penis?
More than double. And what most people miss is the geography of it. The visible part, the glands, is just the tip of the iceberg.
Right, it's a much larger internal structure.
It's shaped like a wishbone, and it extends inches into the body. And understanding that, it changes everything.
And here's the fact that we just need to underline for everyone listening and for their partners.
Yes.
90% of women need some form of direct or indirect clitoral stimulation to reach orgasm.
90%. That is the piece of education that is so often missing. Historically, all the focus was on vaginal penetration as the main event.
And for most women, that's just not where the action is for orgasm.
Exactly. It can feel great, but it doesn't provide that focused, intense nerve stimulation needed to trigger the reflex. It's like you are aiming at the wrong target the whole time.
It also means we have to throw out that old linear model of sexual response, right?
Yeah.
The desire leads to arousal, leads to orgasm.
That model is so often wrong for women. For many, the cycle is much more circular, it's emotional, it's really dependent on mental relaxation.
So desire might actually follow arousal.
It often does. Or it follows a sense of safety or connection. If the mind is cluttered and anxious, the body just stalls.
And that takes us right to the main villain of this story, the anxious brain.
The brain is the largest sexual organ. We say it all the time because it's true. Orgasm is a physiological reflex. It's involuntary.
Like a sneeze.
Exactly like a sneeze. You can't force it. And the moment you start consciously thinking about it, you can shut it down.
So that's the paradox.
That is the ultimate paradox.
Yeah.
The consultation detailed all these mental roadblocks. Pressure to perform, self-critical thoughts, and that killer thought, what if it doesn't work again?
That's a signal of danger to the nervous system.
It is. The doctor in the source had a fantastic analogy for it.
Yeah, tell us that one.
They said trying to have an orgasm while you're anxious is like trying to sneeze while you're thinking, come on, sneeze, sneeze now, you have to do it.
You can't do it.
You can't. That internal monologue just creates tension. Your body interprets that as a need for control. And control is the enemy of surrender.
So it's a physiological freeze response triggered by anxiety. The thinking brain is literally stepping on the brakes.
That's a perfect way to put it. If the brain senses pressure or fear, it suppresses that final involuntary release.
Okay, so let's connect that to some of the root causes. The patient in the consultation described herself as a perfectionist under a lot of work stress. How does that translate to the bedroom?
It translates directly. Perfectionism is all about control. A perfectionist wants to do sex right to get the expected result.
Like it's another task on the to-do list.
Exactly. But orgasm requires the total opposite.
Yeah.
It requires you to surrender control, to start monitoring what's happening, and just get lost in the sensation. The personality trait that makes you great at your job is sabotaging you here.
Wow. And then there's the psycho-emotional side, the shame piece.
Yes. The sources talk about the role of growing up in an environment where sex was taboo.
Or just not talked about at all.
Right. And that internalized shame, it doesn't just stay in your mind. It translates into physical tension in the body. It keeps the pelvic floor tight, the mind anxious, and it maintains that freeze response.
And on top of that, especially for primary anorgasmia, there's often just a real lack of self-exploration.
Absolutely. If a woman has never given herself permission to explore her own body without pressure or guilt, she hasn't built those neural pathways. She hasn't mapped her own pleasure zones. You can't find a destination you've never looked for on a map.
This all sounds pretty complex, but the good news is the treatment plan is actually very structured and, as the consultant said, very treatable.
It is. The protocol that sex therapists use is, it's multi-step, but it's very logical. And step 1 is transformative.
Which is?
Remove the goal.
Okay, so no more trying to have an orgasm.
None. The new objective is simply to understand what feels pleasant, what feels nice or safe or exciting. You're not chasing a finish line anymore.
So what does that look like in practice?
It looks like focusing on the present moment. The warmth, the texture, the connection. You're literally retraining your brain to associate intimacy with relaxation, not with a pass-fail test.
And from there, you move into more specific awareness exercises like breathing.
Yes, this is crucial. So many women unconsciously hold their breath during sex, which just signals danger to the body.
And tightens everything up.
Exactly. So
Yeah.
you practice deep diaphragmatic breathing slowly into the belly. It tells your nervous system that you're safe and allows those involuntary muscles to relax.
I love the concept of touch mapping.
It's a beautiful practice. It's about methodical, non-judgmental exploration of your own body. You're just learning to differentiate sensations. Is this pressure? Is this temperature? Is this a good rhythm? It's not about finding an on button. It's about building a library of what feels good.
And if you're in a relationship, the partner has to be completely on board with this shift.
Oh, 100%. The partner has to understand the anatomy we talked about, and they have to redefine what success means.
So their goal is no longer, I have to make her orgasm.
No. Their goal becomes, I want to help create an environment of pleasure and relaxation. It requires a lot of open, non-judgmental communication.
And for couples, the plan often includes something called sensate focus exercises. What are those?
Sensate Focus is basically a series of structured homework assignments. You start by completely desexualizing touch to remove all the pressure.
So you might start with just non-genital touch.
Exactly. Maybe for a week, you're only allowed to touch each other's backs or hands. The focus is purely on giving and receiving pleasure with zero expectation that it will lead anywhere.
So it's retraining the brain to associate touch with intimacy and calm, not pressure.
That's it. And only once that foundation is solid do you slowly reintroduce genital touch, still with the focus on pleasure, not climax.
And the final piece is the mental work, right? The cognitive reframing.
This is the ongoing practice. It's about actively catching those negative, goal-oriented thoughts like, I should be there by now, and replacing them with mindful statements about what you're actually feeling in the moment. This feels warm, or I am safe.
It's about fighting that urge to self-monitor.
Yes. And the sources are clear, this stuff takes time, but it works. But they also say if you've been trying this for a few months and you feel stuck,
It's not a failure.
it's not a failure at all. It's just an indication that you might need a specialist to help. A certified sex therapist, or a somatic therapist, or even a pelvic floor physiotherapist.
So wrapping all this up, what is the single most important insight someone should walk away with from this deep dive?
That this challenge is overwhelmingly psychological and educational. It is not a fundamental flaw in your body's design.
Your body is capable.
Your body is more than capable. The path forward is about education, and it's about dismantling years of pressure and bad information.
And we have to end on that note of validation from the source material.
Mm.
Orgasm is just one part of sex.
Mm-hmm.
Pleasure, connection, safety.
Mm.
Those are the real goals.
Absolutely. Your worth as a sexual being has nothing to do with whether you cross that finish line.
Right.
And if you're listening and recognizing yourself in this, maybe our final thought for you is this. The decision to seek this knowledge, to talk about it, to start this process, that is the biggest step. The problem isn't abnormal, it's just a learning curve. You are learning, and there is absolutely nothing wrong with that.